Welcome, viewers. Welcome to our show, Orthopaedic Solution Academy. Hope you all are well during this COVID-19 pandemic situation by wearing mask and keeping distance, and definitely by giving the vaccine. Hope our Valentine's Day will be more beautiful after taking the vaccine. Dear viewers, today our topic is achondroplasia, a very important topic, and treatment by Ilizarov, and evolution by the evolution method of the lengthening. So it is a very important topic for the Ilizarov surgeon. And our honorable speaker is Professor Novikov sir from the Russian Institute of Ilizarov. I would like to request Professor Novikov sir to join with us. Hello, sir. Welcome to our show, Orthopaedic
Good
Solution
afternoon. Good
Academy.
afternoon. Can
Good
I
afternoon,
start?
sir. Just a minute, sir. I would like to request our honorable academic expert, Professor Bari sir, the pioneer Elizabeth surgeon in Bangladesh, to join with us. Professor Bari sir.
Thank you so much, Tanveer. Thank you so
Thank you,
much.
sir. Thank you, sir, for joining with us. Dear viewers, Orthopedic Solution Academy is a highly academic program, and today our topic is achondroplasia. Hope you will be benefited from this program. Now, I would like to request our honorable speaker, Professor Novikov sir, to start his excellent presentation regarding achondroplasia treatment by Ilizarov. Professor Novikov sir, would you please start your presentation, sir?
Thank you very much. And I want to say we are happy because this year we celebrate 100 years since Ilizarov birth, 70 years of Ilizarov methods, and 50 years of Kurgan Center. People of low stature have extended at all times. Very rich, poor, everywhere, all country, doesn't matter where, we all time have this situation. King of, daughter of king, big person, small person. The problem of low growth has extended at all times. And so many persons give us information about achondroplasia like Gleason, Perrot, Kaufman, Marie, Volkov, Ilizarov, Katon, Shevtsov, Dror-Paley, Novikov, Klimov, and only with Ilizarov, doctor start step-by-step change of this life. Lengthening, this is example of lengthening, was before Ilizarov. And these slides I took from Jacques Caton, and I want to show Wagner. Before Ilizarov, this great surgeon, professor from Germany, says we can support for patient with achondroplasia only with correction deformity and nothing more. And Ilizarov was first who opened the world's first department of growth regulation near 40 years ago. And now, through this department, more than, very sorry, not 100, 1,000 patients have been treated in Ilizarov Center, Ilizarov department. Indications for surgery, this is disproportional shortening, deformity, all of segments. And very important to do X-rays spine, because sometimes we have severe contraindication with vertebra, and with contraindication severe several somatic condition of a patient, mental disorders, angiotrophic and neurological disorders, and infections. When we talk about time when we can touch first stage of this patient, please remember these 3 periods, because between 4 and 6 years, this is period of delay, then period of equalization, and then period of accelerated majority. This period, second period, better for first stage. This period, not so good for start. This age, we usually continue our treatment. And here we give scheme, different variants of treatment. And please remember, Ilizarov touched this patient more than 50 years ago. First, monofocal, this is another variant, bifocal. Then, after bifocal, doctor need twice touch femur. Ilizarov only once treat one femur, one tibia, same size or same unilateral lengthening, and after this lengthening, function of knee joint was very bad, and I show only like scheme, nothing more, and never recommend this treatment. And then coming another period when we start simultaneous cross lengthening of contralateral tibia and femur. Very quickly, I want to show surgery on the femur. Continued topic of Dr. Bari. This is pre-drilling bone before osteotomy. This is approach for osteotomy, and after this is suturing, and automatically we have reposition if sometimes we have dislocation. For support during the lengthening, we have problem with the soft tissue of knee joint, and for prevent of luxation, we usually put frame on the tibia. Hinges to do reposition automatically. So many years ago, Dr. Ilizarov touched first femur in the world with achondroplasia, and he started lengthening on the proximal part of femur. But big distance between frame give us very interesting situation. Expressed periosteal reaction of the proximal part. Dr. Ilizarov start lengthening on the distal part. Same situation. Expressed periosteal reaction on the distal part. And then Ilizarov start lengthening bifocal. This is first patient in the world when Ilizarov did all of segments with bifocal methods. And so many magazines, journals give information about Roberta Bianchi. After 2 tibias, coming second stage, and to do simultaneous lengthening both of femur, very difficult, with some complications, with many problems. And after this epoch de Ilizarov, I show these slides only like history, only like about methods of our father. And you see how patient after surgery can walk without any support during the lengthening of the tibia and femur too, use only sticks with excellent function. This is patient was near 40 years ago. Then coming time of cross lengthening, simultaneous lengthening. So many patients we touch with bifocal lengthening, but now my experience better to do lengthening with one level, more easy, more quickly, more better, less pain, without any problem with joints. And Ilizarov was genius and did lengthening of humerus after finish lengthening of low extremities. Now many doctors start from humerus. I am not agree give recommendation for baby 4 years old to do, because here we can give this patient each humerus 8-10 centimeters. But if we will start lengthening of humerus with very young patient, maximum 4-6 centimeters, no more. Now this is patient from Poland, and now she work in bank and can use ski in the mountain, has family. And I won't say achondroplasia is a particular area of orthopedics. Why? Because this is orthopedics casus. We especially to do formation of deformity in proximal third of femur. Little bit later I will show. And please not correct varus deformity on tibia. Why? Because during the lengthening, automatically will come in valgus deformity. And if you will, from beginning, did varus correction, then you will against with valgus, big valgus deformity. And not full correct elbow position, bent position of elbow joint, because full unbent position not so comfortable for patient, and sometimes patient not satisfied with full straight of elbow joint. Here we especially to do deformity, anti-curvation deformity, for correction of hyperlordosis, like patient from Poland. I won't repeat again what is it our methods, our magic methods. This is almost bloodless and low invasive surgery. This is very strong firm fixation of bone fragments, early weight bearing of effect limb, function of adjacent joint, and postoperative adjustment of the bone fragments from the time of surgery till the removal of the frame. Постоянно что-то вылетает здесь. And So many dissertation we finished in our center, PhD dissertation, professor dissertation, only with achondroplasia. And now we can talk with another point, from scientific point. Epocha de Ilizarov, we did so big lengthening and collect experience and scientific experience and indications for surgery of treatment. This is not lengthening. This disproportionate shortening of deformity of the limbs. And we solve problems like defect and damage, biomechanics, some social, domestic, and psychological problems. We take into account such aspects of medical and social rehabilitation as biomechanical, ergonomic, and aesthetic. Selection of extension tactics, assessment of factors, elongations, number of segments to be extended, the need for correction, destruction, and rehabilitation potential of the soft tissue and bone tissue. And so many skeletal damage, achondroplasia. And many years ago and now, again, we usually use monofocal lengthening. Sometimes with severe deformity, with bifocal, upper and lower extremities. Very seldom we touch forearm. Usually patient satisfied only with lengthening of humerus. Смотри, что здесь появляется вот это вот. Просто нажимаю все. Да. Все время влетает. And when we start treated, we need to think about ergonomic, clinical, and biomechanical aspect of lengthening. And all embracing assessment of the clinical, anatomical, and functional condition of the patient. Planning of the reconstruction of the musculoskeletal system, and preoperative modeling. Very important. For what we do this? Because everything around of us for our height, not for dwarfism and for patient with achondroplasia. And we need to think about easy axis of control and directing system, easy access to everywhere and control of directing system, easy access to security system. And during the treatment, we use radiography, densitometry, ultrasound, CT scan, volumetry of the extended segment. So many different system of measurement, but we usually use general angles. And when we start lengthening, must think about apophysis. This is my topographic map, and we want to share with our experience how to do muscles change during the lengthening. And we delay to the three groups. First group, muscles which are always lengthening by the entire amount of lengthening. regarding on the number and level of osteotomies. Second groups, muscles which are not elongated. And third group, muscles which lengthening depend on the level of osteotomy. This is very, very important when we touch patient second time. When we talk about the level, think just now, please, to see tuberosities of the delta muscles of deltoideus, because if we will do osteotomy upper or below place of fixation muscles of deltoideus, we will have absolutely different results and so many complications when some doctor to do osteotomy very close to the cap of humerus because muscles of pectoralis go with lengthening very far from place of fixation. Here you can see how during the lengthening change shape of muscles of deltoideus. And we prefer, this is our methods, when we do corticotomy through the place of attaching of deltoid muscles. Here another point when sometimes osteotomy go through place of fixation of patella. Estimation of bone tissue destruction potential. We use radiography, ultrasound, digital bone density analysis, evaluation of the destruction potential of soft tissue, and evaluation of patient's rehabilitation capacity. During the treatment, must all time check all of angles. Sometimes now we haven't, but want again. Many years we use automatically distraction. Now haven't, and very excellent support for us when our colleagues give us information about condition of all of soft tissue, and here like densitometry. Little bit later, I want to explain about this. What is it volume? This is simple measurement, give us very important information about potential condition, potential forces for the lengthening when we measure volume of the muscles and skin. And you see relative volume and absolute volume. And the increase of the absolute volume of limb segment after lengthening is an evidence of soft tissue growth. The constancy of the indicator indicates its dystrophic process. Must, before lengthening, take this information during the lengthening, after lengthening, and very important, before second stage. This is my colleague Oleg Klimov, and maybe inshallah we will together go to the Bangladesh, because he has excellent information about second lengthening of patient with achondroplasia. And here you can see when we can use wire with a lever, or sometimes this is two wires work more than more effective than two wires or wire with a lever. Here, this is system give us support, increase forces on the frame. Here, we will now very seldom use this system, but because very dangerous. But this is two wires give us very good support for osteotomy in proximal part of fibula. And without exercise, we haven't result, and you see how Professor Ilizarov show how patient can take weight bearing and stimulate him for the walking. Genius knew his professor. Two humerus patient from Germany, 35 years ago. This is our hall. Professor Bari and many doctors from Bangladesh were in this hall, and patient come without lift, only with stick. Simultaneous lengthening of both of humerus, more than 10 centimeters, I think near the 12. And so many patients come here, maybe for cinema, maybe for some exhibitions, maybe for concert. And we have excellent rehabilitation, and without our colleagues, we cannot get perfect result. And you see all of patients with extreme big amount of lengthening each time, twice daily. Patients come in gym for exercise. Here we can walk, we show how very easy we can increase function of elbow joint. Here, device for the automatic development of prevention of joints contraction. And now, during the 3 stages, we can finish all of our program, but for height, some patients want second time increase his height, and usually we touch second time only tibia. Here, first patient with cross lengthening, contralateral. This is patient from old Yugoslavia, from Serbia, 35 years ago. Look at this patient, near 50 centimeters increase height. Now he is interpreter and he know very well Chinese and work like interpreter. We twice touch his tibias and humerus. Patient from Korea. All of these patients from Epoca de Ilizarov. This is was after Ilizarov, and you can see 40 centimeters lengthening, 28 centimeters his natural growing, and after treatment he may be upper than his mother. This is only like historical photo. During the day, patient all time spent in corridor with another baby, not lay in the bed. And do you remember I show, please not correct varus deformity. This is patient was first, and Professor Ilizarov start from correction valgus deformity of this patient. After 5-6 centimeters coming valgus deformity, and Professor Shevtsov, me, spent big time, and very difficult was correct valgus deformity. This patient from Italy was second, and we not correct valgus deformity or varus deformity. We only lengthening and varus correct automatically. Now, this patient finished lengthening his tibia 1983. Cessa Marca. Now he is president of biggest association short people in the world, ASAMI. He is from Milan, and so many patients now under this association. And I'm collaborate. If Bangladesh having association, must create, because Russia just now open, and father and mother of this patient very active and support and collaborate with doctor. And you see Cessa Marca, Dror Peili, Hosni, Kamal Hosni, Konstantin Novikov, Algieri, and many doctors from all of the world. Algeria here, what here. One doctor from German, one from French, from German, and all of these doctors use Ilizarov technique for lengthening of extremities, achondroplasia. I am happy because more than 10 years I work with Ilizarov, and he was all time with patient, inside of patient. And now this is monument, this is planet, this is our planet in the sky, this is our philosophy. I am very happy because I have excellent friends all over the world through methods of Ilizarov. Thank you very much for your attention, and I invite you for cooperation and exchanging of our experience.
Thank you very much, sir. Thank you for your nice and brilliant presentation. And I think it will be a milestone for us, and we can follow this technique also, and we can help our people also. Now, I would like to request our honorable academic expert, Professor Bari, sir, to share his knowledge regarding the achondroplastia and the treatment by Ilizarov. Professor Bari, sir, would you please?
Can you hear me?
Yes, sir. We can hear you clearly and loudly, sir.
Okay, you can hear me. First of all, I would like to thank Professor Novikov Konstantin Igorovich for his excellent show-up. He has shown a lot of cases, and during the time of Professor Ilizarov, how he was treated this all kind of achondroplastic patient. And later on, during the time of Professor Vladimir Ivanovich Shevtsov, they have changed their own technique. And the complications that was done by Professor Ilizarov, he showed himself, if you go for the lengthening from the femur fast, and if you go lengthening for the tibia fast, what is happening? And nicely, Professor Novikov showed cross level of lengthening. That is, you can go for the femur and go opposite side with the tibia. When you finish this one, you can go again for the, if you do right side, you can go for the left side. Cross lengthening is very good. And I'm doing myself the cross lengthening, femur and tibia. And sometimes I tried myself to go for the tibia fast, both tibia fast, and I have done the re-lengthening of the tibia. And regarding the treatment procedure, at which age you can start, we rightly mentioned 4 to 6, 7 to 10, and above that. And I myself advise all the patient for doing the achondroplastic lengthening 5 to 6 years. Tibia or femur, right side femur, if you do, you go for the opposite side tibia. If you go to the left side femur, you go to the right side tibia. So there are, if you go for lengthening in the femur, more than beyond 3 or 4 or 5 centimeter, you can invite contracture or stiffness of the knee. So that's why my question to Professor Novikov, what's your suggestion regarding the lengthening of the tibia in achondroplasia patients by monofocal corticotomy? How much lengthening it is advisable for the patient? Otherwise, he deliberately, nicely showed everything, and this is excellent teaching for the young orthopedic surgeons, not only for the Ilizarov surgeons, those who are using the uniaxial fixator and other kind of fixator, as for example, SUB or Taylor special frame. But Ilizarov is still the best among all other external fixators. So my questions to Professor Novikov, what's your suggestions regarding the lengthening of the femur in achondroplasia patient?
Professor Novikov sir, we can't hear you, sir. Professor Novikov sir, please unmute yourself.
Yeah.
Just now?
Yes,
Yeah.
sir, we can hear you clearly.
Yeah, and I want to answer for questions of Dr. Bari. Usually we start from both of tibia, age 6, near 6.
Yes.
Because we need collaborate with patient, and we need think about amount of lengthening. We need think about percentage, not centimeters. Baby 4-5 years has very short tibia, and if we will do how many 5-6 centimeters not enough for achondroplasia. Usually we think about 8-10 centimeters. Baby has 10 centimeters, and 10 centimeters, this is will near 100% of all of tissue. This is, we will kill our result in the future. When we touch baby in the first time, we need to think about second stage. And usually, Epoca de Ilizarov, we think about centimeters. 12, 14, 16, maximum 22. Only imagine patient 14 years old, 22 centimeters. For me, patient was happy. Me, like doctor, unhappy. Why? Because we lost function of foot, ballerina foot, peroneus sensation of both of tibia, not so good walking because patient is limping. And now, for me, Ilizarov all time to do bifocal, because having time and patient need about maximum. For me, better, not small amount, but less than 10. More quickly, more easy, more effective, and give us chance touch this segment second time. Because if we will do with big lengthening, for example, 6-8 years, finished with 12 centimeters of tibia or 10 centimeters of humerus, grow line will closed, and we will close natural potential for growing. And for answer questions, first stage 6 years, after 1-2 years, second time crossed. Then, if patient want, then will not enough, maybe before 20 years, small amount, 6-8 centimeters. Last time we will touch tibia, because when we touch crossed lengthening right tibia, left femur, sometimes we cannot see which will reaction of grow line. And when we will finish lengthening, some valgus, some varus deformity need correction. With correction, we continue small lengthening. And usually now we twice, sometimes 3 times lengthening of lower extremities. And now this is the topic of son of Dr. Bari. Very important. Why? Because just now so many doctors, for example, in Russia, go through our difficulties and repeat our complications our way 30 years ago. For example, this doctor from Moscow, from St. Petersburg, to do lengthening humerus in 4 years. For my opinion, this is mistake, because small baby, 4-6 centimeters for normal life, this is not enough, because span will not enough for как самообслуживание Bari, я забыл. And
helping personal hygiene.
Yeah,
personal hygiene.
And very interesting, achondroplasia in Russia. Now, doctor ask mother and father, why you not think about future this patient? When mother was pregnant, why you not did abort? I am against, because this is baby from God. And if God give chance, must give support. And I think we can, if parents agree, we need give support this patient.
Very good. And regarding Tanvir, I want to add, regarding the tibia lengthening, he rightly mentioned, don't go for correction of the varus, because this kind of patient you'll see that they are with varus deformity. So don't need to correct the varus deformity when you are going for lengthening. It will almost it will correct when you are going for lengthening. This is very important. This is very important tidbit. A lot of surgeons are doing, because they are looking that there is upper part of the tibia, the whole tibia is the varus. So they want to correct at the same time varus with lengthening. So you don't need to correct the varus, because
and
this growth
after 5 centimeters will again correct valgus.
Again, yes. After 5-6 centimeter, if you correct, then again you will get the valgus. So you are creating, by doing varus correction, you are creating valgus. This is very important for the achondroplasia patient. That is the very important thing. This is also very good teaching.
Yes, sir. Thank you, sir, for giving us some valuable tricks and tips. Sir, I have a question. Is there a minimum gap time between the first stage and second stage of lengthening?
Very sorry, but
yes, you can 2 to 3 years. You can start lengthening after 2 to 3 years. Yeah.
At least
we have done,
2 to 3 years.
I have done the cases, and you can see in my book, Color Atlas. You can see in the pediatric, I have done the cases. And you should have to counsel the patient, because this is a continuous process. You cannot do one time. You should have to advise before doing the surgery, lengthening. You must tell your patient and parents that you need to go for re-lengthening. And rightly, Novikov said, don't go for lengthening of the humerus at the age of 4 fast. You go to the how you can sit, how you can drive, how you can bicycle. So that's why lower extremity is very important for doing the lengthening fast in achondroplastic patient. Am I right?
Okay.
Absolutely, you're absolutely right. And when we talk about rest period, this is depend. And when we finish lengthening, must send this patient in the hand of rehabilitation, because after lengthening of femur, we have sometimes, this is true, we have not problem, but temporary bend contracture, extend contracture of knee joint. When second time patient come, if he haven't enough function, full function of knee joint, we not touch them. Now, if patient during the lengthening has small equinus deformity of foot, or absolutely straight knee joint during the lengthening of femur, we immediately stop our lengthening. Function of joint must be same with lengthening. And about how many, which kind of methods variant better, monofocal or bifocal. For soft tissue, better monofocal, but for 10 centimeters, this is so big time for lengthening and maybe not so good. If patient has deformity, sometimes distal part we have deformity, we touch second distal part for correction, small amount of lengthening and normal amount lengthening in proximal part. Femur we touch for correction of lordosis, correction, create anticurvation deformity, small amount of lengthening, and more than 75% of amount of lengthening all of segment we finished in distal part. And now I'm not agree with Dror Paley. Why? Because he do lengthening distal part of femur and same time proximal part of tibia. This is big outer compression for knee joint, area of femur and area of tibia, grow line Hatam. I am not agree. He show excellent, but we need think about future. Just now coming time, and this patient with few patient we did, but result was not so good. We not recommend this. If you during the lengthening patient can, but just now we can calculate which kind of muscles from femur fix here, which kind of muscles from tibia fix on the here, and what will be with these muscles. Next time, I think during this year with son of Dr. Bari, we will show the map with myotopography. Map will change our mind. We will never do big amount of lengthening, and we will never do, for example, this area or this area. So many mistakes doctor did on the humerus, only with level of osteotomy. And just now, please, young doctor, when you only plan, ask Dr. Bari which area better touch for lengthening.
So, sir, would you please tell us about the better area for corticotomy in case of femur? Either it is monofocal or bifocal. Which site will be best site for the corticotomy in femur?
For femur, distal part. Distal part for femur, and proximal part only for correction, a small amount of lengthening for correction of lordosis, but not all patient has severe lordosis. And
so in the proximal part, can you give us any measurement that is it is 2 centimeter below lesser trochanter or 1 centimeter below lesser trochanter? Is there any marking there?
You're absolutely right, doctor. Minimum 2-3 centimeters below
lesser trochanter.
Trochanteric minor. Because me, Professor Ilizarov too, few patients, 3-4 patients, we touch this area. Terrible. Result was terrible. And we lengthening only in proximal part. 7 centimeters, we dislocate place of of muscle.
And we have definitely. Then we have to follow the rules, at least 2 to 3 centimeter below from the lesser trochanter for the proximal part of the femur. Then how far we will go for the distal part of the femur? Is there any measurement from 8 centimeter or 10 centimeter from the knee joint? We have to do corticotomy in the distal part of the femur. Is there any measurement there?
Holy cow, this is grow line. Minimum 4-5 centimeters upper.
Upper of the growth line.
Yeah, like that.
Minimum 4 to 5 centimeter upper from the growth line, not from the joint line.
No joint line.
Okay.
No, no.
Okay.
And soft tissue, this area usually doctor with monolateral use this area for fixation for pins of shunts.
Okay, sir. So then, in case of tibia, what will be the corticotomy site in distal tibia? So how far
Distal
it will be from the joint? Yeah.
Same. We go up of grow line and minimum 3-4 centimeters. And just now we go for osteotomy in distal part of tibia only if we have deformity. Why? Because my experience, yeah, 4 centimeters, this is interesting. 5 centimeters lower part, 8 centimeters proximal part, more than 10 centimeters, but area for lengthening near the ankle joint, not so good. Ankle joint and muscles and tendons, this patient in the future cannot run. Patient with proximal place for lengthening on the tibia can run, can jump, can everything.
Excellent, sir. Excellent. It's a very
monofocal, not bifocal. Slowly, step by step, with bifocal, very quickly, but very quickly come everything. Very quickly become problem.
Yes.
This is problem not go away.
That means, in case of tibia, you suggest a monofocal corticotomy. You prefer monofocal corticotomy. But if we do bifocal, but if we do bifocal corticotomy in case of tibia, but is there any rules that how many distance between two part of corticotomy we have to maintain?
Doctor, colleagues, how we can recommend segment like this? Here knee joint, here ankle joint, here grow line. Now we have only maximum 10 centimeters for job area. One ring, second ring, third ring, sometimes place between proximal and distal wires 8 centimeters for two level. This is not so good.
Right.
When we think about soft tissue, better if between ring we have near 10 centimeters between frame. This result for soft tissue will excellent. When too closed, we will get, but after 2-3 centimeters, all wire will cut soft tissue. What is it? This is market for us. Soft tissue having potential for lengthening. When coming first, cutting of skin, better stop. With bifocal, we all time have this situation when wire cut skin. And not only skin, muscles inside, under skin. With monofocal, it's very small, very seldom we have problem with soft tissue. And now I am prefer better twice monofocal than once bifocal.
Bifocal, yes. Another important complications when you are going for bifocal lengthening, you are inviting equinus. Even if you go for monofocal, you are inviting equinus. That's why to overcome that, you must suggest your patient all the time go for physiotherapy continuous during the procedure of treatment. If you go for bifocal lengthening, you are getting more equinus than unifocal. You understand? That's why these are the very important things. During the process of treatment, you must advise all the time a rehabilitation process before and after surgery, because you will get lengthening, but at the same time you are inviting equinus of the foot. This is very difficult. Sometimes you need to go for the tendoachilis lengthening for this. So that's why keep it in your mind all the time. It is better to go for 2 times, 3 times unifocal lengthening is better. But for getting more lengthening, you can do that, but you're inviting equinus. This is obvious, and we are getting that. These are the teachings.
You're
Thank
absolutely
you.
right, Dr. Bari. And last time I talked about interesting methods of lengthening when we have bifocal. Because 2 millimeters, 1 millimeter proximal, 1 millimeter distal, this is very high speed for soft tissue. And for example, if we go through waves, maximum in the proximal and minimum in the distal,
Distal.
then change like that.
Yes.
This is support. And in other
Yes.
methods, when we give patient myorelaxant, like gabalon, like midacal, from second month after 4 or 5 centimeters, we usually start support with some myorelaxant. Very good. When we will meet,
Myolex, Midocalm, you're going to start. This is
like
he's
that,
talking
Yes, sir.
about it.
like that.
Yes, sir. That means muscle relaxant we prefer after two months.
Of course, because
Yes.
you are creating force over the muscles. For relaxant, this is good. And I
Sir,
always prescribe all the time.
is there any chance to do any common peroneal nerve injury during the lengthening of tibia?
Because you see, when you are doing over stress, you can go that. Otherwise, doing surgery, corticotomy, you can do corticotomy even in the below the muscle covered by the whole muscles. Upper fibula is fully covered. So if you do the lower third, you don't need to, because when you palpate, you can feel this is your fibula. Even then, you prick with your 1.5 or 1.8 K wire, you can hit and you can weaken the K wire by putting the K wire drilling. Then you could just osteotomize. First, you weaken the bone with K wire pushing, drilling K wire 2 or 3. Then you could osteotomize very easily. You can do that. You cannot destroy the common peroneal nerve. When overstretching you go, then this is you can do. Otherwise, no problem with the common peroneal nerve.
That means we can go in the same manner that we go in the corticotomy distraction. That is, Professor Navikov sir says we can make a wave if we do bifocal corticotomy. We can do
Mm.
1 millimeter in the upper part and 0.5 millimeter in the lower part. Then in the second
Yes,
day,
again you can
point,
change.
we can change. We can alter the
Okay.
wave.
That is wave method.
Okay,
Yes.
that is the wave method. Thank you very much, sir. Thank you. Thank you very much
So for
for
for Ilizarov, lot of teachings, lot of
yes.
it is infinite. Lifelong, no finish. Still, I don't know a lot of things of Ilizarov. Still, I'm doing from my residency. How long I'm working? Still new, 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 new. Everything is new. Research work all the time.
And
So that's
Khalid,
why,
with
that's why
achondroplasia,
I always tell the young doctors, if you learn only one technique nicely, you can cover 90% of the trauma and orthopedic problem. Correct?
Yes.
No, because
Yes, sir.
absolutely, absolutely.
absolutely, lot of young surgeons they are just thinking that putting the wires, this is Ilizarov. No, very big things. If you don't go to Kurgan Center, you'll not realize. And that's why I tell all the time, the orthopedic surgeons, once in a life, the Muslims, they're going to the Mecca for Hajj, and orthopedics, they should go to the Ilizarov Center to see what they're doing. Research all the time with dogs, with horses, with these birds, all kinds of they are working, and how
But
to proceed.
Dr. Bari, Mecca is Mecca, but our religion inside of us, and
Mm.
Ilizarov inside of me, inside of you, and this is not depend from place. Everywhere, Ilizarov with me.
Yes.
In China, in Bangladesh, in everywhere. And just now I can call this is planet, this is club
Planet.
of
Yes.
friends of Ilizarov without
Yes.
any place. And I invite
That,
all of you in our club, friends of Ilizarov.
Friends of
thank you, sir.
Ilizarov.
Thank you.
Yes.
Thank you very much, sir, for your invitation. And we hope so. This will be a planet of Elizarov. And definitely, thank you very much, sir, for sharing your knowledge with us. Thank you very much, Professor Mofakarul Bari, sir, for giving your expert opinion. I would like to thank our viewers as because of they are the main part of this program. Please stay with us, and I would like to thank Raj TV for helping us to arrange this type of program, and definitely Rada Pharmaceuticals Limited for sponsoring this program. And I'm Dr. Mohammed Tanvir Ashraf saying bye bye for today, and hope we'll see you in the next Friday with a new topic. Definitely, it will relate with the magical Ilizarov. Till then, bye bye.
Bye-bye. Thank you.
You are watching Raj TV, Jagorone, Bangladesh. Please subscribe.